Hello, my name is Dr. Nikhil Kadle, and I'm a third-year gastroenterology fellow at the University of Florida in Gainesville, Florida. On behalf of myself and our co-authors, I want to thank Gastrointestinal Endoscopy for allowing us to discuss the findings in a recently published paper titled Discrepancy Between Self-Reported and Actual Colonoscopy Polypectomy Practices for the Removal of Small Polyps. As we all know, colorectal cancer is the second highest cause of cancer deaths in the United States, with an estimated 51,020 deaths in the year 2019. Identification and endoscopic removal of colorectal polyps has been shown to reduce the incidence of mortality of colorectal cancer. The majority of colon polyps found on screening colonoscopy are small, measuring less than 10 millimeters in size. Recent data suggest that cold biopsy forceps may be inferior to snare polypectomy in terms of completeness of resection. Hence, recent guidelines recommend snare polypectomy, specifically cold snare polypectomy, as the preferred method for removal of small polyps less than 10 millimeters, because of its high complete resection rates and adequate safety profile. The primary aim of the study was to evaluate and compare polypectomy preferences and practice patterns for the removal of small polyps, defined as those measuring between 4 to 9 millimeters, among endoscopists at a single academic center. A secondary aim was to identify factors associated with the use of cold snare polypectomy. To investigate polypectomy preferences among endoscopists at a single academic medical center, we conducted a 14-item survey questionnaire aimed to evaluate preferences in polypectomy techniques. The electronic survey was sent out to 26 GI faculty endoscopists at the University of Florida, of which 19, or 73%, responded. Overall, nearly 90% of the respondents, or 17 out of 19, indicated that they used cold biopsy forceps for diminutive polyps measuring between 1 to 3 millimeters in size. Conversely, all the participants indicated that they used snare polypectomy for the resection of small polyps measuring between 4 to 9 millimeters in size. More specifically, 17 out of 19 of the respondents, or 90%, indicated that they used cold snare polypectomy, whereas the remainder 2 would use hot snare polypectomy. None of the respondents indicated using cold biopsy forceps as a preferred technique for the removal of these small polyps. When inquired about the reasons for potentially choosing cold biopsy forceps over cold snare polypectomy for the removal of small polyps between 4 to 9 millimeters in size, most respondents indicated that there were no reasons for choosing cold biopsy forceps over cold snare polypectomy. Between 1 to 4 respondents indicated concern for bleeding, availability of device in the endoscopy unit, and faster procedural time with biopsy forceps as potential reason for choosing cold biopsy forceps over cold snare polypectomy. Following completion of the survey questionnaire, we then conducted a retrospective analysis to evaluate the actual polypectomy techniques used for polyp resection during colonoscopies performed by the same endoscopists from January 2016 to September 2018. A total of 1,118 colonoscopies with 2,625 polypectomies of polyps less than 10 millimeters in size were included in the study. The median polyp size was 4 millimeters, and most polyps were sized 4 to 9 millimeters. In terms of morphology, 93% of the polyps were categorized as sessile, with equal distribution between proximal and distant colon locations. Of the 2,625 polyps removed, 59% were adenomas, 5% were serrated adenomas, 27% were hyperplastic polyps, and 9% were normal non-dysplastic colonic mucosa. This figure illustrates the actual polypectomy techniques employed according to polyp size. 90% of the polyps equal or less than 3 millimeters in size were removed with cold biopsy forceps. For small polyp sizes between 4 to 9 millimeters, nearly half of these lesions were also removed with cold biopsy forceps, whereas either hot snare polypectomy and cold snare polypectomy were each utilized in about 27% of these lesions. We then performed a logistic regression analysis to identify potential variables associated with cold snare polypectomy of small polyp size between 4 to 9 millimeters. Interventional endoscopists were more likely than non-interventional endoscopists to remove small polyps with cold snare polypectomy. Conversely, pedunculated polyps were negatively associated with cold snare polypectomy, as noted in this table. Other variables, including patient's age, gender, BMI, indication of the colonoscopy, quality of bowel preparation, polyp location, or training involvement, were not associated with the use of cold snare polypectomy for these polyps. Overall, our study demonstrated that significant discrepancy exists between self-reported preferences and active polypectomy practices among endoscopists. While most endoscopists indicated that they would use cold snare polypectomy for removal of small polyps, on survey questionnaire, retrospective data analysis demonstrated that cold biopsy forceps was preferentially used over snare polypectomy. Our findings have several important clinical implications. For one, our study demonstrates the difficulty of validly measuring practice patterns using self-reported alone. The results from our study do suggest a lack of knowledge or unfamiliarity with guideline recommendations are unlikely reasons for choosing cold biopsy forceps over cold snare polypectomy, as all participants chose the latter as a preferred technique for the removal of small polyps on survey questionnaire. However, this knowledge did not ultimately translate into clinical practice. While we were able to demonstrate that interventional endoscopists were more likely to use cold snare polypectomy for the removal of small polyps, additional studies are needed to identify barriers for the routine application of cold snare polypectomy. Perhaps additional training in basic polypectomy techniques may further enhance the use of snare polypectomy. Irrespectively, in light of the discrepancy between self-reported versus actual practice patterns and the importance of adequately removing these polyps for colorectal cancer prevention, our findings suggest that monitoring and reporting polypectomy techniques should be considered a quality measure for colonoscopy. Thank you so very much for watching this video, and I welcome all viewers to read our article in Gastrointestinal Endoscopy.